Video session. Now we have 3 videos, and the first one will be presented by Jordan Bloom from MGH, who will share with us how he does the ROS as a full root replacement. Jordan.
Thank you, Ismail. Thank you, Maral, Dr. Adams, and Dr. David. It's really kind of an indescribable honor to be invited to speak to this group about the ROS operation. Something that I became very passionate about when I learned it from Duke Cameron, and then decided to go to London and spend a year with one of the last operating living disciples of Donald Ross, a guy called Daryl Shore, who was 74 years old and doing many Rosses still, and I've become a little bit obsessed with the operation, and now technically do it very similar to Ismail, so I'm going to show a video of how I do that, and I have no disclosures. This is a 49-year-old female with bicuspid aortic valve. She was primarily stenosis, but also had some regurgitation as well, as you can see here on her echocardiogram. This is sort of our ROS procedure inclusion checklist. No connective tissue disorder. I think preoperative hypertension screening is critical in these patients. She had normal coronary branching and reasonably good annular size concurrence. I think multiplanar reconstruction with annular tracings by a combination of both transcatheter aortic valve and transcatheter pulmonary valve type imaging studies are great, and we've developed a ROS protocol CT scan where you can get this information. So the operative plan for her was full sternotomy, aortic valve excision, and hopefully a ROS procedure. Her backup plan was a mechanical valve, and she needed a brief period of circulatory rest, which I don't show. Obviously this operation starts with aortic valve inspection and excision. This was just a pretty typical bicuspid aortic valve with left-right fusion. When I took it out, it almost had a bit more of a unicuspid appearance to it with maybe some small commissural fusion. I always get a quick size measurement just so I have an idea in my mind, and then I go inspect the pulmonary valve. We pull down on the heart to put tension on the PA, and I always transect the PA and start the dissection. And then I spend a lot of time on this, and I've actually learned that filling this with saline, I think, creates a magnifying effect, and you can sometimes find fenestrations that you wouldn't have otherwise seen. And I apologize, for some reason the video is choppy, but as you fill with saline and suck it out, you can highlight small fenestrations like this one. Her echo looked really good, so we didn't worry about it, but I am a bit of a chicken with pulmonary valve fenestrations. Then I stop what I'm doing and I go back and take the coronary buttons off, because I have had a couple of right coronary injuries early in my experience, and so I think this makes it safer. And then this patient needed an annuloplasty, so I did the deep dissection like we would for a reimplantation procedure. And then we moved to the separation of the LVOT and RVOT by dividing the infundibular ligament, and the proximity of the left main for this particular patient was pretty scary. Ismail always says you just have to stay right on the pulmonary artery in the autograft to mobilize the left main away from what you're dissecting, and that's kind of what I think in my head whenever I'm doing this. And then the autograft harvest is pretty straightforward with the right angle, approximately 3 to 4 millimeters below the nadir of the sinus, and then sharp dissection all the way around. I've never really been able to use the scissors to do the interventricular septal part, so I still use a scalpel, as shown here, but I do try to make it flat and stay out of the septal perforator. And then I spend an obscene amount of time on this, and I don't worry about the clamp. Duke Cameron taught me how to protect the heart while it was off. But I think this is the most critical part of everything is perfect symmetry. And so I loaded on a small Hager inside out. I know Ismail doesn't like this. And I do my markings. And then I spend some time really carefully analyzing the symmetry, because I've had a lot of asymmetric pulmonary valves. And then this is just an illustration, because some people think that homograph length is mysterious. So what I took out was 4 centimeters in length. So when I go to put something back in, I need 4 centimeters plus another millimeter or 2. And then I use the coroneocone to basically check all of my anatomy before I turn it back right side in. And in this case, it was very elegant. And then we move to the LVOT, and we just recapitulate that symmetry. Today I use the right-left commissure as the reference. That varies each case, and here you can see 60-degree markings across that LVOT. The annuloplasty is conducted, at least the way I do it, with 6 pledgeted stitches. You see those stitches basically go around the level of the basal ring. I used to cut just a Dacron ring at this point, but I've moved to leaving the entire graft as if you were doing a David operation, and then cutting out the left and right coronary sinuses and leaving the non, which you can tack up later, that may or may not help, but I don't think hurts. And then my autograft implantation is very similar to Ismail's. I just take the sutures in the opposite direction because that's the way that Magdi Yaqub taught Torsant, and he told me I should do that. So these are lubricated 5-0 ethibond sutures, but the principles are the same, very deep in the left ventricular outflow tract, so your Ross is completely intraannular. We don't follow the intercommissural triangles, and this is an example in the left non, how those sutures really go around that virtual basal ring and do not travel up to the intercommissural triangles, resulting in a completely planar implantation. After completion of the left sinus, I move the autograft over to position 2, which is across from the surgeon, and I complete the right sinus and the non, and then we parachute it down. It's usually about 30 sutures for me. It takes about 20 minutes to put the sutures in and about 12 minutes to tie them. And then we deliver the baby, as we say to the medical students. And then I place 3 sutures above each of the commissures and get my first sense of whether the valve's going to be competent by just filling this with saline. I'm not sure there's any validity here, but if it ever leaked, it would make me nervous. And then we proceed with just a standard coronary reimplantation. I use a 4-millimeter punch. There's a million ways to do this. I'm not sure it matters. A 5-0 Prolene and just sew the buttons back on. Always really carefully inspect the suture line from the inside to make sure that you're happy. This right button is implanted in the standard fashion. After completion of the buttons, we do the STJ stabilization. This is the scariest anastomosis in all of the Ross, if you ask me, because if this bleeds, it's really challenging to repair. So we really take our time running 5-0 and respect the symmetry, as was mentioned earlier, of the autograft. If it is not 120 by 120, you don't want to pretend that it is when you mark this graft. I then fill this with cardioplegia, and I have about 75 consecutive cases where I measure how much flow it takes to generate a back pressure of 100. And if the flow rate is less than 400 mLs per minute, the valve tends to be competent. I don't think that number would be the same at every institution because it's based on the resistance of your system, but it works well for me. And then we start by placing the El-Hamamsi racing stripes on the homograft here. This is an acellular homograft. I mean, I've been fortunate enough to always have access to Synergraft, and so I try to use it. There is a little bit of color in the muscle, and those of you that have ever decellularized anything know that these probably are not 100% acellular. But I often have the fellow doing this part, but I always tell people not to reduce the sphincter tone here. I think the way you sew this matters. And it's really challenging to have bleeding proximally of this anastomosis, particularly in the area of the LAD. These first proximal sutures are taken very carefully because the LAD can be awful close. And then the first 4 or 5 sutures along the interventricular septum there are taken superficially so you don't injure the first septal perforator, which may be directly under you. And then in this case, it was easy because I had done a hemiarch, so I just had to bevel the grafts and put them together. But often, if I'm sewing to native aorta, this graft, just this stabilization graft only ends up being maybe 3 or 4 rings. So that's the end of that Ross operation, and here's the postoperative echo where things look really pretty good. This is the physiologic leak that we see in the pulmonary valve, often referred to as the pilot light, and so I actually kind of like seeing this in the aortic position because I feel like I didn't mess it up. It's mean gradient of 2, which should never increase. So just wanted to again thank my Ross mentors and the folks that invited me here, and it's really a great honor, and it's been humbling to sit here and listen to all the giants give their talks. Thank you very much.
Excellent, really nice.